Thank you everyone. You're welcome. Thank you for joining us, for sharing this time with us. We know it's been busy for everyone. And so we'll start, and we hope others will join us soon. We are only about 1 minute into start time. And there's about 10 of us on at the moment. All the panelists are here. Thank you. I'll start with the introduction, and afterwards I'll probably tell you more about Zenith Global Health. In brief, Zenith Global Health is a platform set up by healthcare professionals for healthcare professionals in 2016. And the aim is to encourage and foster shared learning, collaboration across board globally, so that we can benchmark what is good for us, for our patients, and for health consumers, as well as a platform for information sharing and knowledge sharing as well. Also, the other aspect of us is the celebrating of healthcare professionals globally. So this afternoon, we are kicking off with a webinar series on women's health. Normally, we'll have a seminar, but we all know that with the present situation, webinar have become the order of the day and the new normal, as everybody calls it. The topic of today, which is birth and pelvic floor trauma, is something close to every woman's heart, I believe, and every family's heart, actually, whether from experience or from observation or from news. So we're really privileged this afternoon to have two thought-leading healthcare professionals who are actually specialists in the area of the art of birth, prevention of trauma during birth, pelvic injury, and also picking up the pieces at the other end when these things happen. So they are skilled, they are knowledgeable, they are experienced in both the prevention, the art of it to ensure optimum outcome, and also the treatment when things doesn't go well, not necessarily from their practice, but from all over the world. So welcome with me this afternoon, Dr. Gloria Esegbuna, who is a consultant obstetrician, and she is the founder of Institute of Women's Health in Africa, and also an innovator and specialist practitioner. With us also is Ms. Susie Elnil, who is also a consultant urogynecologist and uroneurologist. Oh, well, she'll tell us more about that. I used to be urodynamic, so I was so excited when I saw, you know, what it is, because that it means it encompasses everything to do with pelvis, bladder, everything and everything. She'll tell us more about it. She's also an associate professor at UCL, honorary professor at the University of Ibadan, and she's done lots of research in this area as well. So we are very privileged to have the two of you. Thank you and welcome. We'll try and answer your questions and comments. Please don't forget to put them in the comment box. And also at the end, apart from the video, we plan to have a PDF format of things that we've covered today. We are going to kick off with Dr. Esegbuna. Good afternoon, Dr. Esegbuna.
Good afternoon.
Right. So you're welcome to this webinar. Please take us through what you have for us this afternoon.
Okay. So good afternoon, everybody. So my name is Gloria, and my passion is the prevention of trauma to women's bodies from pregnancy and birth and postpartum. And it's something I'm very passionate about because having qualified for about almost 20 years now, I've come to the conclusion that we still believe that it's impossible for women to give birth without trauma. And actually, if you look at the stats and the figures out there, it is very common for women to have quite a number of injuries after birth. So we all know about the tears that you can have from episiotomies or natural tears to the sphincter, you know, the back passage. prolapse, incontinence, some degree of sexual dysfunction. And increasingly, I mean, we as obstetricians and gynecologists don't usually deal with it, but it's very common. There is a condition called diastasis, where a woman at the end of it ends up with a very saggy tummy and almost like a hernia between the muscles in her tummy. So I specialize in obstetrics and gynecology and realized that these things were not really taught about, especially the abdominal injuries. And then the injuries that happen down below in the pelvis, it almost seemed like we couldn't do anything to prevent them as such. I mean, there's a big move now to try and prevent the injury to the back passage, so the sphincter injuries. But I still believe that we see it as inevitable, that if a woman's going to have a vaginal birth, she must have some degree of trauma. So the past 5 years, I'll say about 10 years actually, traveling around Africa, being trained in fistula surgery, and then also as a Winston Churchill Fellow, having the chance to go around the world and go and learn from different practitioners and then work in different settings, I've come to the conclusion, no, it's not true. That actually a lot of the trauma we're seeing in women's bodies is because we are not utilizing properly the 9 months that we have when a woman is pregnant to prepare her body adequately for birth. So we have a situation whereby we are taught about the bones that the baby needs to come through, and maybe a little bit about the pelvic floor, but it's not really a big part of either a doctor's training or midwife's training. And then that's it. So I started to realize that actually our training needs to improve. We need to know a lot more. And then I realized that actually the woman, in terms of knowledge of her body, is compartmentalized. So we have a situation where different people or different specialists have different pieces of the puzzle. So the physiotherapists are very, very good. They kind of understand that there's a lot more to a woman giving birth than just the baby coming through the bones. They understand it's about the muscles and it's about the tissues and it's about the fascia, which is like the soft tissue in between each of those muscles. And then you've got the midwives who are very good at coaching the woman through pregnancy, having that positive mindset, really connecting with the woman, making sure that her hormones are in sync with what her body needs to do. But they're not trained as much as they could be and should be about the muscles and the tissues. And as the obstetricians, we are then left at the other end having to try and deal with what I call pressure issues. So what I want to do, if I can share my screen. I share my screen. Can you see my screen now?
Yes, we can see a beautiful scenery.
Let's see if this will open. Okay, so I'm just going to quickly just take you through one of the models which I've developed of the pregnant woman's body. Just showing you a bit more about the structures which are so important for birth. Now, hopefully this will play and not be a problem. But essentially what I want to show you is that there's so much more to pregnancy and birth than the woman is taught. And I've come to the conclusion after several years, almost a decade of studying this, that it's very important that we really start to educate the woman about birth being about more than what we're showing her. So this is the woman's body here. And so this is the woman's body. And then inside, we're basically just taught that, look, there's a spine. We're not really taught much about the spine, but the spine is very important. We're taught there's a pelvis that the baby needs to come through. And then there's a baby for the pelvis. So if you look at most midwifery and obstetric textbooks, you will have, you know, the fact that this baby's head, which you can see here, needs to come through the pelvis. Let's see if I can get the head here. So the baby's head needs to come through this bony pelvis. But there's so much more to this than that. So for instance, if I hide the baby, for instance, there's a lot of muscular tissue which plays a big part in birth. So up here you've got the diaphragm. So the breathing of the mother is very, very important. You have down here the psoas muscle. And then here, which is very important, is all of the pelvic floor. So if you look at this structure, you can see that it's not so much that the baby's head just needs to come through a big gaping hole. The baby has a very small space to come through, which is here. So if I put that baby's head back now, and let's see if I can hide all of this. You can see, and let's get rid of the baby's body. So this is the baby's head. You can actually see what the baby's head needs to come through this small space here. So all of this tissue here needs to stretch. And I've taken out all of the blood vessels, which are there as well, and the nerves, but all of this tissue needs to stretch. And it's not a question of the baby just neatly plopping through, because unless these tissues can nicely stretch, you can see what happens with the baby's head, that it essentially can tear through all of that tissue. So it's extremely important that we actually start to tell mothers about this. Now, the other reason why this structure is also very important is that when a woman becomes pregnant, all of these muscles have a certain degree of tone, and they can hold the baby up, or they can allow the baby into the pelvis. So this muscle here is very important. This muscle is called the psoas muscle. It's extremely important. So when a woman starts to become, more noticeable in terms of her tummy, her abdomen starts to grow, we find that this psoas muscle can sometimes hold quite a bit of tone. And unless it's able to relax, the baby's head sometimes cannot come through the pelvis. So then we have to start inducing the baby to come down. Inducing the baby to come down means that sometimes you find that you have more tone for the baby to come down. Now, the issue that I have with our pregnancy education at the moment, the 9 months that we have, is that we don't do anything with the mother's tissues at all. Our job, either as midwives or as obstetricians, is just to focus on picking up the pieces. So we wait for there to be a problem with the baby being breached. We wait for there to be a problem with the baby not being in the right position. We try to deal with the fact that the baby is not coming down, that the mother needs to be induced. We even deal with things such as preeclampsia and gestational diabetes, which, if you understand how these muscles work, and if they're very tense, they can actually put up pressure in the rest of the system. You understand that there's a correlation between what's happening with these muscles and all of those other issues that we're dealing with antenatally. But I find it very, very shocking that we are not doing anything to prepare the mother's tissues or bodies for birth at all. We just allow the woman to grow the baby. We don't give her any, and I don't like the word lifestyle, but we don't give her any advice about how she can optimize her tissues such that they open up readily and they allow the baby to come down. And so quite a number of women will now come into pregnancy with very tense tissues, which will not allow the baby to grow outward, will not allow the baby to come down, and a very tight pelvic floor that therefore cannot open readily during birth. And this is the reason why I believe that there is so much trauma from birth. Now, the other thing that we don't educate mothers about is the fact that, as well as their bodies adapting to the pregnancy, they also bring to pregnancy several things. A lot of that is lifestyle. So some of it can be how they think, like being stressed and being anxious. That can also make the muscles very, very tight, especially in the pelvic floor. And if you have a tight pelvic floor, there's a lot of force that's needed to overcome it and to make it open. But also, we come into pregnancy with a lifestyle which is not the best. So we don't stand or squat as much as we used to before. And as a result, our tissues are actually more tense than they could or should be. We tend to use escalators a lot. We sit on chairs and we slouch. So all of these things can actually make the tissues in the tummy and in the pelvis quite tense. And this can affect how the baby comes down, and it can affect how the pelvic floor responds during birth. Now, unfortunately, I don't have an animation, because I had an animation showing you the different effects and how it affects the baby coming down. But this basically is just to show you what the effect is. And even more important than, I would say, the pelvic floor, which are all of these structures here. So there are 3 parts to it. There's the puberococcygeus muscle here, and then the ilio and the ischio-coccygeus. You can see it actually makes a nice bowl. This whole bowl needs to open out nicely during birth. It needs to almost like open out to the sides and lift up so the baby's head can nicely come down. So we are not doing a lot to really optimize that pelvic floor. And I'm not sure if it's very clear here, but even more important than the pelvic floor is the fact that you've got what we call fascia. So all of this soft feathery tissue, which is inside the pelvis, can actually become damaged and broken from how the baby comes down. So there are a lot of things that we don't do in pregnancy to optimize this host structure, which is really, really important. And definitely there's a lot that we don't do in birth to optimize the structure. So if I can, let's see if I can minimize this. So if I can just show you another animation. So in pregnancy, for me, it's extremely important in pregnancy that we optimize the mother's tissues. We really do need to start educating mothers about their tissues and about doing not high impact exercises, but simple exercises such as stretches that will help stretch the tissues in the tummy layer, but also in the pelvic layer. She needs to be taught about breathing, for instance, because there's a big connection between how she breathes with the diaphragm and also the pelvic floor. So we need to teach mothers about all of these things, and we have 9 months to prepare mothers. So alongside picking up the pieces and picking up all of the problems that, as far as I'm concerned, are coming about. So the incontinence, the problems with high blood pressure, you know, the baby not being in the right position, not coming down, as well as dealing with all of that in terms of scans and blood tests, all of the other things that we do for 9 months. It's very important that we start to teach the mother about her body and empower her about her body. And this is really going to need a sea change in not just midwifery, but obstetric education. We are lucky that there's a wealth of information out there when it comes to physiotherapy, even yoga and Pilates are doing quite a lot. But my main issue around that is that it needs to be tailored and specific to the woman, because each woman brings in different configurations of her body to birth and pregnancy. So you cannot have a one size fits all. You know, some women will come in and find that maybe their lower back does not move as much. So they need to have work on the lower back. Some women will come in and find that their tummy muscles are already overstretched and therefore needs help with that. So we need tailored work. And also it's very important that the exercise and the movement that she's taught is very specific to her stage of pregnancy, because what she does in the first trimester up to 13 weeks is very different from what she would do up to 28 weeks and what she would do even at 32 weeks or up to term, up to 40 weeks. So it's very important that, number one, the woman is empowered to understand that. It's not, for me, I feel acceptable that we continue with the stance that we wait until the woman's body breaks down. And then we say, okay, we want to pick up the pieces and understand, you know, pick up the pieces of the birth trauma when we could have prevented it. And then another big area is women then coming into birth with a body which is not optimal because she hasn't been educated how to optimize her body. So she will come into birth, and then we have certain practices, I'll say there are about 30 of them, which are very damaging, not just to the tummy, but to the pelvic structures. This is one of them, which I'm very, very passionate about, which I find still, for me, now, once I discovered it, like a few years ago, I found it quite shocking that we still continue to do it. But it's the question of the legs. Now, I don't know how many of the participants have given birth with their legs in this position. So when you're about to give birth, they say, okay, open your legs to make room for the baby. But it's a very common practice that we have. And it doesn't really matter if she's on the bed. It doesn't matter if she's standing. It doesn't matter if she's in a water birth. But we have this practice whereby when we feel that the woman is fully open and dilated, we start telling her to push. Let me see if I can turn this. So I don't have to look at this. Right, so we have this practice where we actually get the woman to open her legs. We say, open your legs to make more room. And what I want you to actually look at at the back there, you can see some blue tissue. That's the baby's head coming down. And then there's some green tissue, which is part of that pelvic floor. And you can see the natural thing that we ask a woman to do is to open her legs. And when she opens her legs, it actually closes everything down, including the pelvic floor. So that tiny space I was telling you about, which is quite a small space anyway, which needs to open, actually is compromised even more. And so for me, this is one of the big reasons why we have so much trauma, especially in the second stage. Number one, she's coming in with a pelvic floor, which is already tight and contracted anyway because of issues which we haven't dealt with in the pregnancy. And then if she's lucky, she manages to get to fully dilated, the baby's head is coming down. And then almost like she's almost got to the finish line with no trauma. And then we say, open your legs and make room for the baby. And like I said, when we open the legs, it closes things down. But you can see when the knees come together, it actually makes more room. So practices like this are very important. The other practice, which we do quite a lot, is to get the woman to hold her breath and to push. Holding your breath and pushing is very, very dangerous for the pelvic floor. And this is because when you hold your breath and you push, you are not breathing out. You need to breathe out to allow the pelvic floor to rise up and then to open up from side to side and let the baby's head come down. But we have a practice where we get the woman to hold her breath and push, and that essentially keeps the pelvic floor very tight and contracted. And so that practice, along with this, and along with, for instance, in this situation where she's on her back, blocking the back of the pelvis so that the pelvic floor also cannot move, practices such as this are what is causing quite a lot of the trauma. So I have another, I hope this animation will show. This is another animation that basically just shows you a bit more graphically what happens. So you can see here, this is the baby's head. This is the bladder, baby's head, and this is the pelvic floor, and this also is the pelvic floor here. And here is the back passage. So we want this baby's head to come down through this space here. Because we are now closing the pelvic floor, the legs being open, and we're getting her to hold her breath, you're not getting a pelvic floor which is opening nicely. You're getting the pelvic floor which is clenching down. And so that baby has to come down with a lot of force through that pelvic floor. So it's not surprising that we are finding that there's so much trauma. And the other thing I want you to look at what happens to the bowel, this red thing here, and the bladder. So you can see how they can really become very distorted. So it's practices such as this which are causing a lot of trauma. And if you then look at what we define as prolapse, and prolapse which can sometimes cause incontinence, I want you to imagine that baby's head coming down with such great force, and then look at what happens when, maybe let's assume that she's not pregnant. Look at what happens to the bladder and the bowel. You basically have just primed her to have this degree of dysfunction. So for me, there's a lot that we can do antenatally, and a lot of it comes down to education and empowerment of the woman about her body. She really does. I mean, we have 9 months. I keep saying that God has given us 9 months to sort this out. At the moment, I don't think we're utilizing the 9 months as adequately as we could do. We have taken the power away from the woman to understand her body. And until we give that back, we will continue to have very high rates of prolapse and incontinence, which I think is, for me, unforgivable. And I think it's very sad because we don't all have access to great specialists. I mean, we've got Sohair O'Neill on with us on this webinar, but not all women will have access to that. And sometimes the trauma that can occur from birth can be so immense. I mean, if I think about the fistulas I've seen in Africa and some of the extreme bad tears I've seen in the UK, sometimes the trauma can be so immense to the back passage, to the front tissues, that there's nothing that can be done for the mother. And I feel if we can just, I mean, this is something which is so simple. It's so cost effective. It doesn't cost anything to educate women about their bodies. Why are we not doing it? Now, many people will say, well, where's the evidence for this? And I have to say, there's not a lot of evidence. The only evidence I have is that this is how the body works. We know that if we open a woman's legs, we close down everything at the bottom. And it's almost like when it comes to women's health, we are saying that the fact that we haven't done the research is evidence enough. I find that unacceptable. I feel that, you know, having done a lot of independent research in this area for some time, it's almost like we've just decided, well, it's women's health. It doesn't really matter. You know, we've come up with some deficient interventions that can help pick up the pieces, not always effectively. I feel that we need to really start doing more research now. I don't think it's acceptable in 2020 that, let's say, for instance, 85 to 90% of women should have a tear in their bottom. It's unacceptable. And then 50% of women will have some degree of prolapse just because they gave birth. I think that's unacceptable. There are a lot of practices which, especially in the second stage, that we need to overturn, that have no evidence behind them. And definitely there's a lot that we need to do antenatally to prevent women going down that route of being on the table again after they've given birth with prolapse. And then the last thing I will say when it comes to exercise is that there's also another thing that we really need to educate women about, is giving their bodies time to recover and to heal, because it's taken 9 months to grow this baby. It stretched out all the tissues, shortened some other tissues. It takes time for those tissues to go back. And the number one thing which is on mothers' minds when they become pregnant, and especially after they've given birth, is, how do I get my body back? How do I get my body back? Oh, I want to recover. And they're doing all of these really aggressive exercises like crunches and planks, which their body is not designed for. You know, so another thing that we really need to educate mothers about is be gentle with yourself. There's a physiotherapist friend of mine in New York called Marion Ryan, and she said, once you are postpartum, you are always postpartum. And that therefore means that when you've had the baby, it doesn't mean you can immediately go back to doing what you were doing before. You know, the 6 weeks that we give mothers to recover, that 6 weeks is not enough. It takes at least 1 year to get your body back to a semblance of where it was before, especially if you've had some degree of trauma. So the exercises and the movements that you do also have to be very specific and prescriptive for you. In a nutshell, I think all I'm saying is that there's a lot more we need to do in women's health, especially obstetrics and maternity care. I feel we need to really start engaging more with the physiotherapists. We need to empower and improve or allow our midwives to be midwives, because I feel that midwifery education has just been stagnant. Midwives really should know a lot of this stuff, but they're so busy trying to fight their corner just to be allowed to practice as midwives that they haven't even done this research which needs to be done. So there's a lot that we need to do. So we need to really empower and, you know, upscale our midwives to take on quite a lot of the work that the physiotherapists are doing, that the yoga and the Pilates teachers are doing, because there's a lot that they can do antenatally. And then postpartum, we need to really have strength in empowering women about their bodies, and making sure that every woman has access to physiotherapy, whether it's face-to-face, virtual, whether it's just training, but women need to understand their bodies. Thank you. So that's me, I'm done. Anything else?
Thanks, Gloria. Yeah, thank you very much. That was intensive, and I can feel a lot of concentration going on there. About to like encourage people to actually chat. Thank you so much. And I believe that at the end of this, we're all going to have lots of golden nuggets to take away, both to be able to optimize the birth process and also to empower our patients, and also to upskill and do what is necessary, either through asking our departments or hospital for a way forward on how to implement these things, because after all, we are patient advocates. Please don't forget to put your comments in the box, and also the question and answer for later on, so that it can be all interactive. And welcome to those who have just joined us. We've had Dr. Esegbuna sharing with us the art of birth, and what we need to do. Is interesting to know that actually preparing for birth should start from when we are pregnant. You know, even as a midwife, that's something that I'll be taking home as well. So I'm going to welcome Ms. Neil to do her presentation, and then we'll have our question and answer sessions. Thank you. Welcome, Susie.
Well, good evening, everybody. Nice to be with you. As always, I find Gloria's talks fascinating, particularly with all the beautiful modelling, because it really makes it very easy to understand. And she's absolutely right. The starting point for pelvic floor dysfunction is often from the beginning of the whole process of pregnancy, and you could actually go back to preparation, and perhaps one day we'll talk about that, of the pelvic floor from when we are children, really, how to look after it and how to make sure we don't get into problems. So I'll start sharing my screen, and we'll be looking really at the consequences of dysfunction. And what I thought we could do is really look at it from the point of view of what are the possibilities that can go wrong. So I'm going to sort of take on from where Gloria finished, and I will take it forward. So the question is, why are we prone to these conditions? This is a statuette from 4th century, and you can see that everything's to women, everything from the obesity aspects, the fact that they also are breastfeeders, they are pregnant, etc. And although there's generally a well-accepted dictum that we have a lot of issues as women, particularly pregnancy and childbirth and aging, equally we've got inherited genetic factors, and more recently within the United Kingdom there is a lot more emphasis on that as well, particularly the connective tissue disorders, which hitherto had not really been noted in women, but actually the hyperflexibility, the hypermobility on what happens to them in pregnancy and labour, and often they're overlooked. They're seen as the women who have easy births, but actually an easy birth could be setting you up for other problems later on as well. So there's the difficult birth because of all the obstructive elements that Gloria has discussed, and then you've got the so-called super easy precipitate birth, and so nothing is prepared again from that perspective, and huge damage can occur. Now, Gloria showed you beautiful pictures about what happens, and she said she deliberately took out all the nerves and vessels so that the clarity to see what was small with the pelvic floor muscles, the most important nerves that come into the pelvis from the lower sacrum, and the blood vessels. And during childbirth, head goes into the pelvis, it sits there. Now it sits there before you get that particular baby's head out, impacts anteriorly to the bladder, posteriorly to the rectum, centrally to the vagina, and of course don't forget all the nerves can be affected around the back, as well as compromise with ischemia, potential neuropathy, as well as damage. So if you look at pelvic floor anatomy, this is another way of looking at it. You've got here the sacral promontory, that's at the back of the bone, the pelvic here colon, the uterus, and the bladder. So when you have a pregnancy or baby, so even if you have a cesarean section, the mere fact that you've had that pressure point on the floor for a significant period of time is already a factor impacting on the outcome. And I've just put this up because this sort of shows you a more clearer view. If you've got a baby coming out through the pelvic floor, important for pelvic organs, if those go and they get disrupted, particularly if you've had either tears or episiotomies, this is the area that gets disrupted. You end up with the potential for prolapse, continence, the ischiocavernosus for the anus, and of course the bulbocavernosus, which has already been alluded to. So you can see the mere fact that you've got any pressure points in this whole area, and then trauma to these areas. And bear in mind, muscles do not repair with muscle, they repair with scarring, strong, and so therefore from a functional support point of view it's limited, and from a functional element to provide organ function is also limited. So what about the pelvic floor disorders? Well, I think every woman knows about stress incontinence, so what we call intractable overactivity. You can get dysfunction of voiding, so the ability to void and retention issues. You can get bladder pain, you can get fistulas, and so on. And if you look at every organ adjacent to the pelvic. Now, one of the things about urinary stress incontinence, and this is quite important, is that if you look at, that's really 70% of women, if they undergo lifestyle and behavioral changes, by that I mean preventative strategies, losing weight, not putting pressure on the pelvic floor, etc., and put out the rest of these steps. They do not need any further surgery. So that sort of situation, if you can manage to do all of that pre-even children, or during, you can end up not having to have any further input. However, there are what we would call more conservative surgical approaches, which are minor or day case procedures before going to reconstructive surgery, and perhaps even sphincters. In stress incontinence, the problem is the whole support system has gone. And you can see from the nice images we support of the bladder neck, and the urethra can occur. So actually what the surgery does is focus on restoration of those organs to return continence to normal. More complex and more difficult is prolapse, and I took out the picture of the prolapse because it is quite marked. But again, if you look at it, how do you manage it? Lifestyle and behavioral changes, pelvic floor physiotherapy. So if all of that is instituted around the time of childbearing and after childbirth, you may also be able to get away without any surgery at all. You can use pessaries, actually things you can institute, and it could prevent you from having major surgery. You can then go on to other surgery with or without mesh, and as you know, there's a current controversy on that issue. So therefore, you know, anything that can avoid you having any major intervention is important. And I think another important point is that very often prolapse very rarely occurs as an isolated condition. Often it impacts on either bladder or bowel incontinence. There's always some degree of laxity of the sphincters, dysfunction, and so on. So you need to be aware of that. And then, of course, you can go on to major reconstructive surgery. And I think one of the things I would say as a surgeon in this field is it is the fact that we have so many operations for different conditions that really raises the fact that why do we have so many? It's because, one, the condition is very complex. Two, there's no one specific operation that has worked perfectly for any of them. And so therefore, people keep on coming up with variations on a theme, adding bits, taking bits away. So if we can avoid all the pink boxes and stick with the non-pink boxes, we may be able to avoid all this recurrent problem. And there is a lot of evidence in the literature that over 30% of patients who have prolapse surgery will need further prolapse surgery within 10 years. So it is a major issue. You don't really want to go into that realm if you can avoid it. Now, overactive bladder, which is a big favourite with people in my field, whereby you get what we call frequency and urgency, where you rush around from to the toilet, needing to go, and if you don't get there, you can leak, is a huge area of research and interest for many people. But the reality is we still don't understand the true, complete pathophysiology of this. We know there's a neurological component where the nerves may be affected. We also know that in women who have got any prolapse or other dysfunction, it often is associated with some degree of overactivity. Now, the most important thing about treatment here is you want to improve at least 50% of your patient's symptoms. So you want to reduce their need to go to the toilet. So instead of going 5 to 6 times a day, you want, which is the normal, they're going 12, 20 times a day. So you're trying to reduce that time and try and bring them back into a normal realm. But at the same time, you want to have minimal side effects. So we know that different medication can help, but often it's associated with dry mouth, with narcolepsy. They have difficulty with constipation and so on. I've just put this up briefly just to explain that really this area here, the red area here with the pelvis and the nerves in the pelvis, are what often are very much damaged during childbirth. And it's so this area here where you're getting the provision and input from the nerves, from the bladder, the urethra, needs to integrate with the spinal cord and go up into the main 2 centers in the brain where you control the bladder, for instance, and bowel function. And these 2 areas are usually not damaged during neurological disease. They often do get away quite well, except if you have major strokes, and communicate the pelvic information all the way to the brain, you can understand why dysfunction would occur. Now, even if you've got good communication up here, but the nerves aren't available to do the work down here, then nothing will happen. It won't work as you'd like it to. Well, how do you manage very basic things? Lifestyle and behavioral changes, the use of medications such as anticholinergics. More recently, in the last 2 decades, has been the use of Botox, where we use it directly in the bladder, and then, of course, other things like neuromodulation and so on. But once again, you can see the starting point is all to focus on. With regards to neuromodulation, which is effectively a sort of a pacemaker system, can come in different forms. You can use it at the lower leg, and I'll show you TNS, which is like an acupuncture system where you stimulate the peripheral nerve, but it has a central effect impacting on your bladder function and bowel function. Very nice, very patients like it. It is, you come in, you sit down for half an hour, you have that done once a week for 12 weeks, and then after that, sustainable in a health system. And you need to look at other devices which are either implantable or maybe looking at a home device using adhesive patches and so on. This is more typical. A lot of you would have heard of sacral neuromodulation, which is used for a whole host of things. And I think it's important to see the breadth of the condition. So you're using it for frequency and urgency of urine, incontinence conditions, retention, constipation, and fecal incontinence. And I'm sure many people would say, well, how can one device fix so many things? Well, they're all the same things going wrong. It's the same organs in the pelvis affected by the same nervous system. So all those sacral nerves you saw impacted on by the baby's fetal head are actually the same nerve systems that supply the bladder, the vagina, the uterus, the rectum, and the anus. So if there's damage to that system, you can see it will impact on other things. And once again, I would just remind everybody that actually one organ is not always the only feature. So although women might present to you with incontinence of urine, if you take a careful history, often there is a bowel effect, often there is a vaginal effect, a pain effect. You need to take into account all those problems. And these are just some of the outcomes, roughly from the literature, of success when you use this electronic system. And it can be up to 80%, 90%, and so on. But sustainability is an issue. It is an electrical system, and it does require replacement in some cases, although newer devices can be used long term. So there are lots of opportunities for change, and there's lots of opportunities to use this, particularly in birth trauma, and maybe we will have to use it in the future. But once again, by the time you get to this stage, it pretty much shows you that all the other preventative stages haven't been followed, and we need to be focusing on trying to prevent us getting to this stage. I've put in dysfunction, so avoiding dysfunction and retention, because it's often quite missed in women. We are all very well versed on urinary stress incontinence and how it works and doesn't work, but we're not as well versed as what happens when we can't pee. And this is just a classification system showing that your bladder sometimes can go completely the opposite way, and it's just as debilitating and miserable. And so looking at how to help those conditions is important. So just as the nerves can go in the condition to the direction of inducing incontinence, they can equally go to the other direction and do absolutely nothing. So you get no messages at all, your bladder doesn't get any messages, your bowel doesn't get any messages, etc. And so therefore it doesn't function appropriately. Again, in dysfunction like this, you have to look at all the factors, and you have to look at the role of catheterization, which has, of course, has issues with recurrent infections, dilatation, which many of the times you have to repeat it every 3 months, and again, neuromodulation or reconstructive surgery. So again, you really want to avoid being there. And then perhaps looking at the whole of the childbirth injury story. So Gloria's alluded to genital tract fistulas, which I've been doing a lot of work on since the 90s. I've already mentioned prolapse and incontinence. We've heard about perineal trauma. There's also chronic infections, postpartum hemorrhage, and pain. And on top of all of this, and this is something we're recognizing more, is the issue of mental health problems, which impact on all of this. And of course, there's also the history of domestic violence. Now, you'd have thought, how does this all fit in? Well, a woman who can't function because of her pelvic floor dysfunction often becomes the target within environments where she can be hurt, not because of the dysfunction per se, but because of her limitations of interacting either with her children or doing her house commitments. And this is a global issue. Different countries have different levels, and I think it is important. The scope of the problem is not just the trauma as we're thinking about it on the pelvic floor, it's all the other overriding issues. And if you speak to women who have intractable incontinence or difficulty with their bladder, their bowel, or their prolapse, often there is elements of anxiety, depression. You know, they do not want to do certain things. They become a little bit, they pull back on themselves, and they go through phases where they can cope with it and other phases they can't. So it's a really big factor. You can't just deal with one aspect of it. You need to look at the whole picture. Now, Gloria's already talked about fistula, and I started working in fistula a long, long time ago, and I think it's important because if you're looking at the worst case scenario of postpartum trauma or obstetric trauma, this is probably it. So it is a huge problem. The only major cause of it in most under-resourced settings is often obstetric injury. That is the #1 cause. If you look at the factors of maternal mortality rates, and it is related to that, so Scandinavia with maternal mortality, in Africa it can be as bad as 1 in 12, but it's not bad in every country. If you then assume that for every woman that dies, 20 will have morbidity states, you can imagine it's big. Now, again, I bring you back to this diagram, and it shows you here quite clearly getting the impact. So in this sort of situation, I'll just do it slowly so you can see impacting in the pelvis, and then the whole area becomes chronic because the impacting fetal head is stuck there because they have not been able to deliver for days. And that requires the soft tissue. Often you can get impact on the bone in the front and the back. So you're no longer just dealing with the surrounding veins and nerves and soft tissue, but you're impacting on everything. So those of you who have obstetric fistula will see them having difficulty walking, sitting, and so on. Very well known as fistula surgeon in northern Nigeria, and I've put in bits and pieces to sort of clarify. But you can see that if you have trauma predominantly in the front, you can end up with significant trauma to the urethra and to the bladder anteriorly. If you have it more at the back, you're likely to get. If you have compression all the way around, you can actually get not just the areas around where the head is impacted in the pelvis to the bony structures and soft tissue there, but it can impact on the entire pelvic floor. And if you see these patients, sometimes they will slough off an entire bladder. I mean, that is how bad it can be. And then you can have you get the pressure grades out. So it's not unusual if you go to certain, has not just affected the vaginal component, but actually the vaginal walls, the labia, and so on. So there's a huge impact of this trauma. This is sort of the worst case scenario. And this is just to show you what it can look like. So you can have the bladder in the front, the vagina behind, and you can end up with a hole between the two. So urine is dribbling down the whole time. You can get holes in the bladder or the rectum. So you can have holes everywhere. And basically it is like setting off a bomb in your bladder, and you end up with it trying to heal with scarring and infection and continuous urinary dribble. So it's quite traumatic. And this is the worst end of the spectrum, but you can see it doesn't matter where you are on the spectrum. Because often bowel is overlooked. There's a huge amount on the bladder, and we don't focus so much on the bowel. So again, bowel dysfunction, lifestyle and behavioral changes is key, and you try really hard to avoid these two pink boxes. And by bowel dysfunction, it can be incontinence, it can be constipation, it can be evacuation, it can even be attaining flinch. So a lot of us who look after women after childbirth, the first thing they'll tell you is they can't hold it causes them when they're sitting in company and so on. And it's something you also see in women as they go into the menopause. Their sphincters become less stronger and so on, and suddenly they'll lose air, and it's very, very embarrassing, just the noise and so on. So a lot of this can be prevented by these interventions to go down that route, but if you had to go down that route, you can see it's quite significant. And then the other thing I think we always forget is pelvic pain. So there's a tendency in pain to think of it as a trans patients who have had long-standing problems with pelvic floor dysfunction. Pain becomes a contributor to that, and it becomes part of the chronic picture. We could almost have a whole separate webinar just on pelvic pain. I mean, it could just, and it would probably last a few hours. It's so informative, and also a lot of discussion about how the mechanisms are and so on. So you have to look at your bladder symptoms, for instance. You can give them medications such as anticholinergics, but if it's mainly the painful bladder, so every time they pee or fill up, etc., after ruling out there's no infections, you need to think about things like neuropathic analgesics. And probably the best way is to approach it in an MDT, so multidisciplinary approach with pain physicians, physiotherapy, psychology, and pain management, prevention as well as treatment. And I've just put in our pain algorithm, which we run at University College Hospital. And again, we focus very much on this, on lifestyle behavioral changes and analgesics, and often to look at what sort of gynecology, neurology, surgery, and childbirth they've had before bringing them into an MDT or genital system. Mutilations, neurological, it's usually a slightly different type. But again, it's bringing patients in together, understanding what's happening, and then discussing it and making plans for treatment. But the main focal point is really at the very beginning. And lastly but not least is sexual dysfunction. And I think one of the things women are quite embarrassed to talk about, particularly after trauma, is sex. And a lot of the time, they don't want to broach it to get back to a sexual relationship, even though many are usually tired and exhausted having had a child. And if they've had a traumatic delivery, it's 6 to 12 weeks minimum of some degree of recovery, not even full recovery. And often this is overlooked. It needs to be something that's discussed on a regular basis. So if you're looking after women who have suffered any form of obstetric trauma and who come to you, you need to bring in this discussion. It's about that. So it's not something to be ignored. I have had women come and say, when they've broached this subject, that they were told, well, you know, you're lucky you're not leaking, or you're not lucky your baby's doing great, and so if you can't have sex and it's painful, you know, that's your least of your problems. It isn't. You know, to most women, this is an important function, and it needs to be to do it. And most of the time, it involves physiotherapy and looking at hormonal issues. So the way we work really is looking at a multidisciplinary approach, and that includes the patient's buy-in. The patient needs to be part, or the woman needs to be part of this, about discussions of what they would like, how they'd like it delivered, and when, because timing is also key. So you need to look at a multidisciplinary. It is efficacious in multiple pelvic floor disorders. You need careful patient select profiles you can do or you can offer, and you should offer everything to everybody. It should be about patient choice or woman's choice, and help given to them as and when. I think one of the things we often see is because the trauma is often underplayed, the conditions of the pelvic floor dysfunction is often left languishing for decades. So it's not 50s, having suffered a trauma in her 30s, and the first time the trauma is being addressed is when she's in her 50s. So that is quite a dramatic time period for someone to live through with complex problems. And I think probably the most senior woman I looked after was a lady who was 71 years old, who'd had her first child. She ended up with a severe 3rd degree tear, so she had complete disruption of her sphincter, and had lived with it for 50 years, not knowing, or not daring to mention or talk about it, and not knowing that it could have been repaired 50 years previously, or could have potentially been looked into 50 years previously. And that to me is just the sadness about the way women's lives are left to languish for a long time, when there are things you can do to prevent it and then to simply treat it, because a lot of women do not want major surgery. And then if surgical options are there, approach it, the woman as to what she'd like done and when she'd like it done. So working as a team, really. Thank you.
Right. Thank you so much, Susie, for that informative session. I now see clearly why in a recent, I recently read that report. I can't remember when the study was carried out. Over 27% of healthcare professionals said they wouldn't discuss the physical and psychological implication of birth and pelvic floor trauma with their patients. Because you can see, you don't want to sit in front of either a new mother or somebody who's come to you with marital problems and say, this is what's going to happen. But like Gloria said earlier, it's important to not only prevent, but to address. And also, as you mentioned, Susie, to give, to see beyond the patient, to see beyond the trauma, and to see other things that may come with it, like the domestic violence and the mental issue, which, is an entire topic by itself in women's health during this series. And we have a few questions